Hello, my name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the second of three 2026 Early Stage Investigator Lectures. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields and are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the Q&A pod. You'll need to open the pod by hovering your cursor at the top of the Teams window and then clicking on the Q&A icon. We will open the floor to questions at the end of the lecture. The video recording of the lecture will be posted on our website in the coming weeks. We're excited to present the second of our 2026 awardees, Dr. Daniel Corwin. Dr. Corwin is a pediatric emergency medicine attending physician, assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania, director of clinical and translational research for the Division of Emergency Medicine at Children's Hospital of Philadelphia, associate director and emergency department lead of the CHOP Minds Matter Concussion Program, and scholar and leadership council member for CHOP's Center for Injury Research and Prevention. His research program focuses on improving mild traumatic brain injury diagnosis and risk stratification across care settings, including using objective physiological and molecular markers of injury to facilitate timely and accurate diagnosis, addressing health outcome differences in TBI care, including exploring innovative care models such as utilizing digital health and remote patient management to facilitate healthcare system navigation, and evaluating early therapeutics for mild TBI, including leading the first randomized trial of a nutraceutical to improve mild TBI symptoms for the pediatric population. In today's lecture, Dr. Corwin will discuss how the Minds Matter Concussion Program at Children's Hospital of Philadelphia has used a broad array of strategies to try to improve outcomes in children with mild traumatic brain injury. This includes developing evaluation techniques that allow frontline clinicians to assess brain function post-injury using advanced physiologic measures and leveraging digital health to assist patients and families in navigating the health system, while the field continues to innovate around the optimal treatment strategies themselves. Ultimately, the goal is to allow for a precision medicine approach, the right treatment for the right patient at the right time, to be available to all pediatric concussion patients. Please join me in welcoming Dr. Corwin.
Thank you so much, Dr. Murray. This really is an overwhelming honor, and I'm just so extraordinarily excited to be able to share some of the work we're doing here in the Minds Matter program at Children's Hospital of Philadelphia. Before I dive in, I have a few disclosures, and that starts with, and these are probably the two most important slides I have, acknowledging the absolutely amazing mentorship team that I've been lucky enough to be surrounded by through the early stages of my career. I am just so extraordinarily grateful to this amazing group of clinicians, researchers, and most importantly, human beings who have guided and supported and inspired the work that I'll be sharing with you this morning. I also want to acknowledge our incredible Minds Matter team at CHOP, made up of an incredibly dedicated group of clinicians, researchers, and staff who really just inspire me every single day with their commitment to improving the care of pediatric patients with concussion. By way of some more traditional disclosures, I have no financial relationships to disclose. I'll note that the research I'll be sharing is funded in part by competitive grants from the organizations and foundations listed on the slide here, including the NIH. I will be discussing off-label use of branched-chain amino acid supplementation as a concussion therapeutic, and I'll be sharing several patient videos and images with permission. So in thinking about building an acute care concussion research program, we've really grounded the program in the idea of innovation. And when we talk about innovation as it relates to concussion, we have to start by talking about innovation around our management strategies themselves. Concussion is one of the rare conditions across medicine where in the span of just a generation, we've seen really dramatic swings in the pendulum of management, where 30 to 40 years ago, this was you got your bell rung, you tough it out and go right back into play. And then 25 years ago, we took that pendulum and swung it 180 degrees in the other direction and began recommending indefinite rest for all pediatric patients with head trauma. No screens, no school, no sports, no real anything at all until symptoms completely resolve. And importantly, over the last decade, we've evolved beyond this one-size-fits-all approach of just rest, where now we have some really well-proven active targeted therapeutic approaches. And this includes heart rate targeted aerobic exercise therapy, which across multiple clinical trials, including one of the largest shown in the graph here, has been demonstrated to reduce the incidence of persisting concussion symptoms. Targeted vision and vestibular therapy, which has been demonstrated to not only reduce the burden of visuovestibular deficits, but also improve recovery times. And then cognitive rehabilitation in the form of return to school with targeted accommodations. And when these therapeutic strategies are prescribed to our patients in a multimodal fashion, they do quite well. The issue, and this is a bit the double-edged sword of innovation, is that even in 2026, these therapies are nearly exclusively prescribed by concussion specialists. Yet when we look where within the healthcare setting our patients with concussion first present, we find that very few are first presenting to the specialty care setting. This is a look across the CHOP care network, which includes over 30 primary care sites, 2 emergency departments, and 7 sites where patients can receive concussion specialty care throughout southeastern Pennsylvania and southern New Jersey. I see the majority of our concussion patients are first entering the healthcare system through their primary care pediatrician, with a good chunk seeking care through the emergency department. We can look at these populations in a bit more depth. This is data over a 5-year period, over 15,000 patients with concussion, comparing those first seen in the emergency department setting to those first seen in primary and specialty care, and looking at 3 sociodemographic variables: age, race and ethnicity, and insurance. And we see quite striking differences. Starting with age, the percent of patients in the youngest age group first presenting to primary and specialty care is significantly lower than first presenting to the emergency department. In terms of race and ethnicity, the percent of patients identifying as non-Hispanic Black first presenting to primary and specialty care is substantially lower than the percent first presenting to the emergency department, as is the percent of patients possessing public insurance first presenting to primary and specialty care when compared to the ED. We can also zoom out and look at some neighborhood level measures of opportunity, including the median income of the zip code where a patient resides, and the median percent of adults in that zip code who possess a bachelor's degree or higher. Numbers right here for the emergency department patients, and these are nearly twice as high for our patients first seen in primary and specialty care. And then we can look at a single composite measure of opportunity at the neighborhood level, known as the Child Opportunity Index. And this incorporates 44 different indicators that are important to the health and growth and development of children. They span 3 domains. There's an educational domain, a health and environmental domain, and a social and economic domain. And each of the individual indicators, each of the 3 domain scores, and then an overall score, are all scaled from 0, representing the least opportunity, that is the lighter blue on the map here, through 100, representing the most opportunity, that is the darker blue. And our average for that overall score for our emergency department population is 30 out of 100. That number is nearly 3 times higher for our patients first seen in primary and specialty care. And then if we look at just the education domain, which I'd argue of the 3 is probably the most important, it's really our job as pediatricians to get our children following concussion back into school. The average for our ED patient population is just 22 out of 100, so barely in the second quintile. And that number is 4 times higher for our patients first seen in primary and specialty care. And if you're wondering at home, why is a pediatric emergency medicine physician devoting a career to researching concussion, this right here is a big part of my own personal why. We also have to keep in mind that the healthcare system journey is not a static one. So there are a few things in medicine where we've completed our treatment at the same time as we're delivering a diagnosis. And certainly for concussion, with these individualized therapeutic strategies, close follow-up is an extraordinarily important part of the healthcare system journey. And there are phenomenons described in health services research where as a patient is navigating through a path, there are multiple places at which they can fall off the pathway. And when we think about concussion, we've identified 3 critical junctures in the healthcare system journey of our patients. First, following head trauma, our patient needs to be diagnosed with a concussion. We can't really treat what we haven't diagnosed. Then following diagnosis, if we want our patient to receive specialized interventions, they have to first be referred to the specialty care setting. And then ultimately, they have to attend a specialty care visit. So what does our patient population look like as they're navigating through this healthcare system journey? This is over 20,000 patients seen over a 6-year period in our emergency departments. And we're taking a look at patients with head trauma. And of the 20,000 plus patients with head trauma, 6,000 were diagnosed with concussion. 1,100 of those diagnosed were referred to a specialist. And of those 1,100 referred, about 500 attended a specialty visit. And as patients navigate through this system or this healthcare system journey, we're looking at 4 different sociodemographic features, the same as before: age, race and ethnicity, insurance, and then the overall child opportunity index score. Starting with age, our original population of patients with head trauma on average is 7 years old, and that increases and increases and increases as we go through these junctures. From a race and ethnicity standpoint, nearly 50% of our patients with head trauma identify as non-Hispanic Black. But as we go through, that decreases and decreases and decreases. While simultaneously, the percent identifying as non-Hispanic White is increasing at each of these steps. The percent possessing public insurance is decreasing at each of these steps. And then when we get to the overall child opportunity index score, we start with a population where the average score is 40 out of 100. By the time we get to those who are able to attend a specialty visit, that number is all the way up to 72 out of 100. So this tells us at each juncture, our patients who are falling off the path are also our patients with the lowest resources. Brings up the question, do these differences in how and where and when patients first present ultimately lead to differences in outcomes? This was a study where we were investigating whether or not there were differences in recovery between male and female adolescents. Here we're looking at 3 different measures of recovery: the normalization of neurocognitive testing, return to exercise, and return to school. Each took significantly longer to achieve for our female adolescents. But when we adjusted for time from injury to first visit and only looked at those patients seen within a week of injury, all of the differences disappeared. And in fact, on average, the female patients were seen in specialty care 1 week later than their male peers. So the innovation towards these active targeted therapeutic approaches represents a tremendous advance in concussion care, but now we have to think about how can we use innovation to get them into the hands of the patients who will most benefit. So there are 3 strategies that I'll be discussing. The first is changing the way that our providers interface with our patients. And we're lucky enough to do that with a brand new framework known as the CBIM framework. As long as I've been practicing medicine, and honestly, as long as I've been alive, we've had one single classification system for traumatic brain injury: mild, moderate, and severe, based on the very first Glasgow Coma Scale score a patient has when they present to the hospital. There are lots of issues with this classification framework. So in 2022, the NIH and NINDS brought together a group of nearly 100 world experts in TBI. I know several of those experts are listening in today, so I want to thank them for their extraordinary work. But they developed this framework to let us get much more both pragmatic and specific in terms of our diagnostic ability for traumatic brain injury. And we can use this framework to think about how can we get specialized evaluation techniques into the hands of our patients who will most benefit from them, and into the hands of our clinicians who are on the front lines of concussion diagnosis. That includes things like physiovestibular deficits, where we've known for a bit of time that a key part of the persisting symptom burden that our patients experience is related to deficits in the physiovestibular system. But historically, this has only been assessed in concussion specialty clinics. So over the last decade and a half in the Minds Matter program, we have developed and refined and validated a series of physical exam maneuvers known as the visuovestibular examination, or VVE, that allows our frontline clinicians to assess for these very important deficits. In an efficient manner, this 9-part exam takes only about 2 to 3 minutes to perform. Without substantial training, our clinicians can become proficient in this exam with only about 30 minutes of training and practice. And in a broad age range, we've validated this in children as young as 5 years of age. To give you a sense of what some of our patients look like on this testing, this young man is trying to perform vertical saccades. So he's being asked to look rapidly between the examiner's fingers that are sitting at about his forehead and at about his sternal notch. He's just trying to look up and down, but you see as he does so, he begins very quickly to get some rotary eye movements. And this is certainly one of the more dramatic examples of abnormal vertical saccades. But as you watch these videos, I want you to begin to think about what day-to-day life might be like for these patients. This young woman is performing the vestibulo-ocular reflex, so she is staring at the examiner's thumb while she shakes her head. And she should be able to do this for at least 20 repetitions before she experiences any symptoms. But you see, as she begins to shake her head with just 1 or 2 repetitions, she starts getting quite symptomatic. Lots of blinking, lots of wincing, like right there. And then finally, this young man is performing a complex tandem gait. And his standard gait from a standard neurologic exam is totally normal. But when we ask him to walk feet in tandem with his hands at his sides, first forward, then closing his eyes and doing the same backward, we see him begin as he's closing his eyes to develop truncal sway. Take a look at his shoulders as he's walking forward, and then as he's coming backwards, multiple steps off a straight line. So how does this exam do diagnostically? We took a look at over 150 patients presenting to our emergency department with head trauma, about half of whom met criteria for concussion, and compared the scoring on the exam for those with and without concussion. You see, as we accumulate more and more deficits on this exam, it is more and more likely that our patient has a concussion and meets concussion criteria. And we can turn this bar chart into a receiver operating characteristic curve, comparing the sensitivity versus the specificity of this diagnostic test, where we take the area underneath it, or AUC, as a measure of the test's diagnostic accuracy. And we find just for this 2 to 3 minute exam, an AUC of 0.81. So it's getting us 81% of the way there to a diagnosis of concussion. After several implementation strategies, we found very high adoption of physiovestibular testing by our frontline clinicians, where today over 70% of our patients in both the primary care as well as the emergency department setting will receive a physiovestibular examination upon diagnosis. And it really has changed the way that our clinicians diagnose concussion. After implementation, we took a look at a group of patients that our clinicians were able to diagnose from the emergency department with concussion on their very first visit to care, with a group who required multiple visits to ultimately receive that diagnosis. The immediate diagnosis group was significantly more likely, 80% versus just 37%, to have physiovestibular testing performed on that first visit. And when we look at recovery, the delayed diagnosis group had longer recoveries, and after several adjustments, found over 4 times increased odds of persisting symptoms for our group who had the delayed diagnoses. So physiovestibular testing represents an extremely important advance. And when I talk with my emergency medicine colleagues, often the question I get is, I don't have a lot of time. If I only had to do one thing as an evaluation tool, what would it be? And that's my answer. But it's also important for us to continue to push the envelope in terms of allowing for our clinicians to get even more objective measures to use in their toolkit. And we're exploring several different device-based measures of injury, one of which is quantitative pupillometry. And historically, this has been used in the intensive care unit setting for patients with severe disorders of consciousness. But based on the idea that there is an imbalance of sympathetic and parasympathetic tone for our concussion patients, we hypothesized that we might find differences between our patients with and without concussion. This is how pupillometry works. There's a bright white light stimulus that's introduced to the patient's eye. The pupil constricts. After about a second, that stimulus goes away. The pupil redilates. And along the way, we measure various diameters. It's numbers 1, 5, and 9, as well as constriction and dilation velocities. This is what this looks like on a real live human. So when the examiner releases their thumb, the light stimulus is introduced. You'll see the pupil constrict. That stimulus goes away after a second. The pupil redilates. And then we get this really lovely plot with several different metrics from the device. We've found that we can perform this in children as young as 4 years of age within just a couple of hours of injury. So what do our patients look like on this testing? We took a group of 130 patients without concussion, compared them to 100 with concussion enrolled from our concussion specialty clinics, and took a look at 7 different of the metrics of the pupillometer: the maximum and minimum pupil size, the percent that pupil constricts, and then the average and peak constriction and dilation velocities. Here are the numbers for our 2 groups of patients. I'll first point out that all 7 of these metrics are significantly different after Bonferroni correction between the patients with and without concussion, and with AUCs up into the mid to high 0.7s, as high as 0.78 for maximum pupil diameter. There are a couple of pieces of this data that I want to call out specifically. The first is the directionality of the difference. So we're looking at here for maximum pupil diameter that for our concussion patients, the pupil size is larger than our patients without concussion. And as we go through, minimum pupil diameter is also larger. Our constriction velocities are faster. Our dilation velocities are faster. This carries through all 7 metrics. This is actually the reverse of what we see for our patients with more severe disorders of consciousness in the intensive care unit setting. It makes sense that there's a bit of hyperstimulation of the sympathetic portion of the autonomic nervous system for our concussion patients. The other feature I want to point out is that, as I mentioned, these are patients enrolled from our concussion clinic. So these are patients seen 5, 7, 10 days out from injury. And I've introduced this as something that could help our frontline clinicians who are seeing patients much more acutely following the injury. So how does this perform within a couple of days of injury? We're looking at a different patient population, nearly 200 patients with concussion, evaluated as soon as 2 hours out from injury and as far out as 10 days from injury. And this is just the maximum pupil diameter, but we can superimpose here the upper and lower bound of our control values. And starting with that subacute period, the 5, 7, 10 days out, we see relatively stable values for our concussion patients. The blue line represents the maximum pupil diameter for our concussion patients at this time period, and you see it's really closely hugging the upper bound of the control patients. When we look within the first couple days, however, we see much more significant differences and even more hyperstimulation of that sympathetic tone. And that actually carries through the majority of the pupillometry metrics, this trend, where we see even larger pupil sizes, even faster velocities within the first day to 2 after injury. So still much to be done in terms of writing the story of quantitative pupillometry, but some really promising early results. The other area that presents a lot of promise are molecular biomarkers. And in thinking about that CBIM framework, this is the B of CBIM, and there are many potential candidate biomarkers for traumatic brain injury. These include, as seen in the slide here, various proteins from neurons, from astroglial cells, from the lymphatic system, that are released and oftentimes cross the blood-brain barrier and can be measured peripherally following a traumatic brain injury. The 2 most well-studied of these are an astroglial protein, glial fibrillary acidic protein, or GFAP, and a neuronal enzyme, ubiquitin carboxy terminal hydrolase L1, or UCHL1. Like a lot in pediatrics, our early data about these biomarkers came from the adult population. There have been several very large studies of how these biomarkers perform in adults. This is from the ALERT TBI trial, one of the largest. The primary outcome here was not concussion, but signs of intracranial injury on neuroimaging. The researchers found that the combination of these biomarkers and looking for signs of intracranial injury on CT had very, very high sensitivity with near perfect negative predictive value. And because of this work, in 2018, the FDA approved these 2 biomarkers for use by acute care clinicians evaluating patients with traumatic brain injury in the adult population. There's a saying in pediatrics, it's kind of hammered into us on day 1 of a pediatrics residency, and that is children are not just little adults. So how do these biomarkers perform in the pediatric population? There are several ongoing, really fabulous consortiums that are investigating how these biomarkers can work in children. We're lucky enough to be part of one of the largest of these consortiums. This is the pediatric arm of the TRACK TBI network. We have ongoing studies enrolling patients as young as 2 months of age following head trauma, assessing these biomarkers acutely, and then following their correlation with both clinical outcomes as well as advanced neuroimaging within 1 to 2 weeks of injury. Still collecting data in this regard, but we have some really interesting preliminary results as a consortium. The first is thinking about normative values, and in that mantra of children are not just little adults, we have to think about how do our pediatric patients without brain injury perform on these molecular biomarkers. So on the left is UCHL1, on the right is GFAP. This is over 360 patients as young as 3 months of age. And you see as we get into the younger age patients, for each of the biomarkers, there's a little bit of an uptick in the best fit line of the normative values. And in thinking of that ALERT TBI trial, there was a single cut point for each of the biomarkers that led to that very high sensitivity and near perfect negative predictive value. That cut point is what led to FDA approval. So we can superimpose that cut point on these 2 graphs. First, for UCHL1, we see the majority of our pediatric patients have a normative value that is living below this line. Then in our youngest age patients, the trend line is kind of getting close to this green normative value in adults. And then for GFAP, a good number of our pediatric patients have values without brain injury that are above the line. And in fact, every single patient less than 3.5 years of age in this study had a value that was above the normative cut point for adults. So we have to be really thoughtful in thinking about how we apply these biomarkers to children. That being said, we've done some modeling studies that show they have tremendous potential. So I'm thinking about something called clinically important traumatic brain injury. This is a traumatic brain injury that requires something like neurosurgery or multiple days in the hospital setting. We have a really extraordinarily well-performing and well-validated clinical decision rule in pediatrics from the Pediatric Emergency Care Applied Research Network, or PCARN. It tells us when patients are at low enough risk of that outcome that we can spare them neuroimaging. Not surprisingly, we're really cautious about overexposing growing brains to unnecessary neuroradiation. That being said, in the 17 years since that study was first published, despite evidence that at individual institutions and centers, it can lower the rates of unnecessary CT, as a country, we haven't seen large reductions in how we obtain neuroimaging in children. So it brings up the question, could molecular biomarkers also serve purpose in this setting? So in this modeling study, we took a look at various incidences of those clinically important traumatic brain injuries on the x-axis with an outcome of expected value. So that is balancing the risk of missing an important traumatic brain injury with the risk of overexposing a child to unnecessary radiation. And we found at all incidences of clinically important traumatic brain injury, a strategy that employed these molecular biomarkers was the highest performing strategy. So still lots to come in terms of writing the story of these molecular biomarkers, but before we move on from them, I want to introduce the possibility that they can be used not just diagnostically as we're talking about here. So this comes from the FDA's BEST resource, which identifies 7 different types of biomarkers. Certainly there are diagnostic biomarkers. But when we think about these molecular biomarkers and their potential, they also have potential for things like monitoring and response. And as we think about these active targeted therapeutic approaches, like aerobic exercise therapy or vision and vestibular therapy, we have a general sense of what underlies their effectiveness. But if we were able to measure, as patients were undergoing these rehabilitative therapies, what is happening at the cellular level can give us even more information as we think about more closely targeting them to the most appropriate patient population. That was all related to diagnosis. And as we come back to our healthcare system journey here, mentioned that our job is not done with a diagnosis. If we want our concussion patients to see a specialist, oftentimes we have to refer them. And that's important because of this right here. So this is a conceptual model of current care from the primary care setting for our concussion patients. And generally, we haven't asked our primary care pediatricians to do much by the way of early referral. We generally say a patient should be managed in primary care, and if they are still symptomatic at a month out from injury, and that turns out to be about 30% of our pediatric concussion patients, at that point they should be referred to a concussion specialist. And part of the reason we haven't asked them to do early risk stratification is that it's quite tricky to risk stratify acutely pediatric concussion patients. Our largest risk model to date comes from our wonderful neighbors to the north in Canada, the 5P study, that enrolled over 3,000 pediatric patients with concussion, all within 48 hours of injury across 9 Canadian emergency departments. They collected a bunch of features at that first emergency department visit and used them to predict what would ultimately lead to having persisting symptoms 1 month out from injury. The risk model they developed is known as the 5P rule. The R-receive curve for the 5P rule is in the light blue here. And the area under the curve for their validation cohort was 0.68. So moderate discrimination at distinguishing between those with and without concussion, and with and without persisting concussion symptoms. What was particularly interesting about this study is that every patient had a treating physician, and every treating physician was asked, how likely is it that your patient will go on to have persisting symptoms? The AUC for physicians' prediction alone, 0.55. So we as emergency medicine physicians are barely better than a coin flip at predicting which of our patients will go on to have persisting symptoms. So this 0.68 represents an important advance in the care of pediatric concussion patients. That being said, we can move the needle a bit more, coming back to our old friends, the vestibular deficits, which are not just beneficial diagnostically, but also have prognostic value. Part of the reason why I tell my emergency medicine colleagues that it's such a valuable test to perform. We took a look at each of the 9 individual exam elements and their association with persisting symptoms after concussion, which we call PSAC, and found that all 9 were significantly associated with persisting symptoms, and with odds ratios 3.3, 3.7, 4.5, that well exceed what we see for any individual symptom. We can turn this into a single vestibular exam score, add it to the 5P rule, and find we get a nice bump in predictive power. where the combination of the 5P rule with visiovestibular deficits gets us an AUC into the mid-0.7s. We are taking a look at how this strategy can perform in the primary care setting. This is part of a cooperative award from the Centers for Disease Control and Prevention and the Minds Matter program. And we're looking at altering this current conceptual model of care to using these tools, having our primary care pediatricians risk stratify at the very first visit to care, which occurs in the primary care setting on average 4 to 5 days out from injury. And if a patient is deemed to be high risk, immediately referring them at that early stage to a concussion specialist. And we're doing so with an electronic clinical decision support tool that I think is rather elegant. This is the brainchild of one of our fabulous informaticians here at CHOP, Dr. Jeremy Michael. And it takes advantage of Epic's Note Writer template. So the EHR at CHOP is Epic, and a Note Writer, as a clinician is going through and documenting, they're asked to click various buttons. So on the left in the red square here, the light green represents individual concussion symptoms. The light blue represents the visiovestibular exam elements. First, as the provider is clicking on these buttons in real time, they get a note that's documented for them, which really helps from an efficiency standpoint. But even more importantly, they get in real time the 2 risk stratification scores, a 5P score and a VVE score. Once they are done documenting, they have a hyperlink here. Once clicked on, it gives a pop-up and informs them whether or not for that individual patient, specialty referral is recommended. It's all without having to leave the electronic health record, the individual encounter, or having to do any calculations as a clinician. We think this will improve care for all of our pediatric concussion patients, but we have a particular lens on our patients cared for in the urban settings. So in community practices, where the resources at the neighborhood level might not be as robust as their peers in suburban settings. So we've taken 6 of the 31 primary care sites in the CHOP network, paired an urban and suburban site, and in a step wedge fashion, rolled out this electronic clinical decision support tool, the ECDS tool, at 12-month blocks. We have both effectiveness and implementation outcomes as part of this trial. We just finished enrollment a couple of weeks ago, so we're just diving into the effectiveness data, but have some really interesting early results from the implementation data. So over the 3-year period, we enrolled over 1,100 patients. Of those patients, 82% had the electronic tool utilized when the clinician was evaluating them for concussion. So if nothing else, our clinicians are finding use in this decision support tool. Everything I just mentioned was related to changing the way our clinicians are interfacing with our patients, and I will bring back the healthcare system journey one more time to reintroduce the idea that our job doesn't end with providing a referral. We need to get our patients in front of the specialist and remind you of these really stark differences after referral in the group who ultimately attends a specialty visit from a child opportunity index standpoint versus those who do not. Well, this tells us that even if with perfect accuracy we could diagnose concussion, whether it be with a clinical exam, a device-based measure, a molecular biomarker, and even if we could use a combination of those tools to predict with perfect accuracy which patients would have persisting symptoms, we still would have extra work to do in terms of getting our patients in front of the specialists. Our jobs would not be done. So I'll bring up another conceptual model, this time from the emergency department. It looks very similar to the conceptual model from the primary care setting. We have on the left our initial group of patients with a concussion. The light gray of the pie chart represent those who will go on to have persisting symptoms. And once they leave the emergency department, they enter into a stage of passive interaction with the healthcare system. They are doing some kind of activity, they are experiencing some kind of symptoms, but generally we don't know what that is. Now, with the advent of this handy little device that lives in all of our pockets, it's easier than it's ever been to get information from a patient in the moment. Our first foray into remote patient monitoring was about a dozen years ago. We equipped a group of patients from our concussion specialty clinic with iPod touches. Hopefully folks still remember what iPods were. But in 2014, smartphones were not as ubiquitous as they are today. On the iPod Touch was an app that queried the patients 3 times a day about their symptoms. And historically, over the 3-week period of this study, we would get 1, maybe 2, and at most 3 data points from our patients. But you see, by getting this daily information, we get really interesting granular data about the daily fluctuations in symptom burden. And it also lets us to get really granular with association testing. So in addition to the iPod, every patient was equipped with an accelerometer to measure their step count. We tested associations like, is there an association between step count and symptom burden? And ultimately, we found that increasing step count was associated with decreasing symptom burden. But because we had data every single day from these patients, we could generate a plot such as this, which is called a cross-correlation plot, that shows us the temporality of that relationship. In this case, the decrease in symptom burden occurred on average 2 days after the increase in step count. So we get to move from an association, increasing step count is associated with decreasing symptom burden, to perhaps a causation. Because it occurs first, perhaps the increase in step count is actually driving the decrease in symptom burden. This also lets us get really granular with outcome definition in clinical trials. So I mentioned early on the benefits of heart rate targeted aerobic exercise therapy and showed a small graph of one of the largest clinical trials of aerobic exercise therapy in the pediatric population. That was a multi-center study out of the University of Buffalo, Boston Children's, and here at CHOP. And the primary outcome for that study that demonstrated the effectiveness of aerobic exercise therapy was recovery as determined by an in-person visit with a clinician. In addition to that, every participant in the study had a very similar app to the prior study, now installed on their own smartphones. Smartphones are ubiquitous enough that we can use the patient's smartphone as part of this trial. And a very similar approach, 3 times a day, symptoms were queried. And in addition to that primary outcome of clinical clearance, there was a recovery definition whereby when their daily symptom burden reached the pre-injury symptom levels, they were deemed recovered. And in this plot, we're looking at the relationship between the two. The y-axis is the in-person recovery, the x-axis is the mobile health recovery, and each dot represents an individual patient. I think you can see this relationship a bit better with these Kaplan-Meier curves, where the green line represents the app-based definition, the orange line, the in-person definition. They mirror each other quite closely, but that green line is shifted a bit to the left. On average, recovery as determined by the app-based definition occurred 3 days before recovery as determined by the in-person definition. Now, this first foray into remote monitoring was a group of patients enrolled from specialty care. All of the patients from CHOP enrolled in this clinical trial were enrolled from specialty care. Hopefully, I've imparted upon you that the patients we care for in the emergency department are just a different patient population than those who are seen in specialty care, with a particular lens on follow-up, where it can be extraordinarily challenging for our patients first seen in the emergency department. These are 2 studies, one in children, one in adults, nearly identical findings. Less than 50% of patients diagnosed with concussion in the emergency department setting will ever have a follow-up again after discharge, whether that be their primary care clinician, another acute care clinician, a specialist. Less than half. This is a number I share all the time with my emergency medicine colleagues. It is more likely than not that you will be the only clinician who's delivering concussion-specific guidance to the patient in front of you. So how does remote monitoring work from the ED setting? We did a pilot study of 30 adolescents, equipped them with a very similar strategy to the clinical trial, used their own smartphone, installed an app that queried them 3 times a day about their symptom burden. This is the overall demographics in terms of age, sex, race and ethnicity, insurance, and injury mechanism for the population. That pretty closely mirrors the overall concussion patient population from the emergency department. And we found over a 3-week period that 60% of the prompts were responded to. We had a couple of different strategies to try to encourage responsiveness. Even in our lowest performing strategy, we had a response rate of over 50%. So 3 prompts a day over a 3-week period. It's over 30 data points from our ED patients where historically we might not have any. And as we were using this technology to track our concussion patients from the ED, we also began to think about, could we use it to intervene and really flip this care model on its head? This makes up the crux of my current K23 award, where rather than this passive interaction with the healthcare system, the second our patient leaves the emergency department, we begin tracking their symptoms, their activity. We feed back to them in real time some management strategies. But for those patients who are not recovering in the way we expect, we immediately send an alert to our concussion specialty team, who can pull patients into care well before they traditionally would have. And we're taking a look in my K23 at the feasibility of this approach. We're using a slightly different platform. This is a web-based platform to conduct this trial. Very similar setup in terms of querying patients about symptoms and activity. We're now doing this only once a day. We've done a lot of usability testing and heard from the adolescents that 3 times a day is just too much. But we're asking them about individual symptoms, as you see in the screenshot on the left. As they are endorsing a symptom, they're asked to rate the symptom, which lets us generate an overall symptom score. We also ask questions about medication utilization, about activity. And then as they're answering these questions from these two highlighted boxes, they are getting back in real time some management strategies. But what's particularly exciting for us about this approach is that every single one of their answers is immediately integrated into our electronic health record. And this is data from a real life participant in this study. We're looking at an EPIC flow sheet, something that generally we'd be using as clinicians to trend things like vital signs or lab values. But here we're looking at trends in individual concussion symptoms across multiple days, trends in the overall concussion symptom burden, and trends in adherence to things like aerobic exercise and home eye tracking exercises. And we can turn any of those values into a recovery plot, such as this. And this is the overall symptom burden for this participant, where we see first escalating and then plateauing symptoms, neither of which we would expect, and both of which trigger an alert to our specialty team, who then immediately reach out to the patient to begin delivering specialty care. And they're able to do so with one additional tool in their toolkit, and that is the idea of telemedicine. There are, I think for all of us, very few silver linings of the COVID pandemic. I think really the only one I can identify is right here, and that's the increased use of telemedicine. This pie chart on the screen represents from over 5,000 visits that occurred in our concussion specialty care setting, the percent that were conducted by telemedicine in the calendar year 2019. And I say it's a pie chart, but it's not, it's just a circle because we had 0 telemedicine visits in that calendar year. And in a huge testament to the adaptability and flexibility and creativity of our concussion specialty clinicians, that number jumped all the way up to 40% in the calendar year 2020. And this is what telemedicine in terms of a concussion evaluation looks like. This is one of our nurse practitioners performing a visuovestibular exam virtually. On the left, she's assessing the vestibulo-ocular reflex. On the right, she's observing a complex tandem gait. And we find we get very similar information doing this virtually as we do doing it in person. So we're taking a look at what this approach, remote monitoring with the option of telemedicine, can do to specialty care engagement for our emergency department population. Nearly done with enrollment in this study. This number is actually up to 106 after the last couple of days, and a wonderful testament to the fabulous team we have in the Minds Matter program. But we're comparing to the traditional referral model. Here's a phone number. You call, you schedule the appointment. Once the appointment day occurs, you have to get transportation to the appointment. And once you are physically in person in front of the specialist, then only do you begin receiving specialty care. That leads to an interaction rate of about 35%. This remote monitoring approach in our preliminary data nearly doubles that engagement rate. And then we're also using this technology to encourage adherence and compliance with specialty interventions. So when I mentioned the rehabilitative strategies, there are home versions of each of those, home aerobic exercise therapy, home eye tracking exercises that have been shown to have a good deal of efficacy. So we can also use this remote monitoring technology to encourage engagement with those. And we found that with daily reminders about doing these exercises, we get over 70% engagement in eye tracking exercises and over 90% engagement in aerobic exercise. So we're really excited about this feasibility data. What's next for us is taking a look at what this does for effectiveness and really seeing what this approach can do for our recovery trajectories of our pediatric concussion patients. And then with my last couple of minutes, I just want to briefly mention changing the therapies themselves. So anyone who's ever been to physical therapy can identify with the fact that while effective, it can be very time and labor intensive. So what if there was a concussion pharmacologic that we had? And if we think about those molecular biomarkers, they all present potential therapeutic targets, but those are years down the line from being ready for prime time. So what might be available for our clinicians a little bit more expeditiously? This is based in work from a wonderful neuroscientist here at CHOP, Dr. Akiva Corwin, who over the last couple of decades has demonstrated that the 3 branched-chain amino acids, leucine, isoleucine, and valine, are selectively and significantly reduced in animal models following concussion. He's found that supplementing those branched-chain amino acids not only normalizes their levels in the animal models, but also improves cognitive and memory function. So how does this work in humans? We conducted the first clinical trial of branched-chain amino acid supplementation in any age population with concussion in a group of adolescents and young adults. This was actually the first targeted clinical trial of concussion from a pharmacologic standpoint. And this is very preliminary data. So over an 8-year period, we enrolled 40 participants That included COVID. There was some missingness in data. We had 5 different arms, a placebo arm, and then 4 different dosing arms. But though preliminary, some really promising signal within the preliminary data. So on the x-axis here, we're looking at the cumulative study drug that our patients consumed over the 3-week study period on the x-axis, and then on the y-axis, we're looking at the change in symptom burden over that 3-week period, where a more negative number represents a larger decrease in symptom burden. We find in what seems to be a dose-response fashion that the more study drug consumed, the larger the reduction in symptom burden. We can also look at things like physical activity and have very similar findings. Here, increased is improved, so a larger improvement in physical activity, a higher number, is indicative of a better recovery. The more study drug consumed in a dose-response fashion, the larger the improvement in physical activity. And because of this preliminary data, we were able to secure funding for a phase 3 trial that we are very excited to hopefully launch within the next couple of weeks. But ultimately, our hope by deploying this set of strategies, changing the way our providers interact with our patients, changing the way our patients interact with the healthcare system, and then changing the therapies themselves, we can really move concussion to a precision medicine approach. The right treatment, not just the one-size-fits-all of everybody rest, but the active targeted therapeutic approaches, perhaps a targeted pharmacologic, for the right patient, not just the patient who happens to have access to specialty care, but the patient who is at highest risk of experiencing the worst outcomes, and at the right time, not waiting for weeks to months out from injury for a patient to self-identify as being in trouble, but pulling them into care much more expeditiously in the course of their recovery. Before I break for questions, I just one last time want to recognize the amazing mentorship team that I have around me, as well as our phenomenal Minds Matter team. With that, I will thank you once again for this extraordinarily incredible honor, and as well for your time and attention, and look forward to any questions that I can answer. Thank you.
Thank you, Dr. Corwin. A terrific presentation. Thank you very much for all of this. A bunch of questions. So I'm going back to the earliest slides that you showed, looking at where pediatric concussion patients are first seen. And there were more of them seen in primary care than other places. Is that because those injuries were relatively mild and the parents weren't so concerned? I'm just curious why they didn't go straight to the ER.
Yeah, and there are several reasons driving that. And as part of this, we're conducting several qualitative studies to understand the why are patients presenting. And you'd think there'd be a pretty direct correlation. More severe injury means you're going to the emergency department, but it turns out that's not the case. And in thinking of all those social determinants of health, a big driver of utilizing the emergency department is when are you available to take your child to the emergency department or to seek care? So if you have the ability to take off from work and bring your child in the middle of the day, on a weekday, it's easier to get into an outpatient clinic. The only time you can seek care is 12 in the morning, 1 in the morning, or late at night on a weekend, then you're kind of stuck seeking care from the emergency department.
Understood. If I read the numbers correctly, if we added up the proportions seen in primary care, in the ED, and in specialty care, it might have added up to something less than 35 or 40%, and it's suggesting that most people were seen somewhere else. Maybe I misread the figure.
I can go all the way back, but it is 100%. It's about 80% in the primary care setting. It's about 15% in the emergency department, and then about 5% in specialty care.
Okay, thank you. That misread on my part.
No, it's okay. I went through a lot of stuff really quickly.
You talked about a couple of measurement procedures, visiovestibular, pupillometry. They seem to be good indicators of concussion in kids. Are those used in CHOP only? Are they disseminated more widely? What's the status of uptake of those kinds of measures?
Yeah, and you're hitting on a key part of what is next in terms of our line of work, and that's really embracing implementation science to see how we can get these measures implemented outside of the 4 walls of CHOP. And there are some conditions of rare diseases where it makes sense to bring every patient with that disease to an academic tertiary medical center like CHOP. There are 2 million concussions in kids each year, so that is physically impossible, and we want them to be evaluated close to home and near their medical home. So we have begun doing work, and some of this is funded by some philanthropic grants from the Toyota Way Forward Fund, looking at implementation in varied emergency departments, including community emergency departments. And when we look at where our pediatric concussion patients are seen, it's actually only about 10 to 15% that come to the large academic emergency departments. Most go to their smaller community EDs, where the workflow is very different. The training for clinicians is very different. I think their jobs are much more difficult. I get to stop thinking about patients when they're 18. A community emergency medicine physician has to think about the entire lifespan. So that implementation is just different. That being said, we've seen really high uptake in these early implementation studies, which suggests to us that clinicians are also finding value in this testing. But I think it comes back to there's so many evaluation tools. If you just Google concussion evaluation tools on your computer, you're going to be overwhelmed with what's available out there, and providing really the streamlined, efficient evaluation technique. If I tell an emergency medicine clinician they're going to have to spend 15 minutes evaluating a concussion patient, I'm going to get laughed out of the room. But if I say you can get a lot of information and demonstrate that information in only about 2 to 3 minutes, then we get more buy-in. So still early in that widespread implementation, but some really promising results from the clinical testing. I think the device-based measures and the molecular biomarkers are a different story in terms of they require very different implementation strategies. Now we're introducing the idea of a device and having to purchase the device or spend money on a blood test. So I think what's additionally appealing for us about the physiovestibular testing is you really don't need a lot of equipment. You need your fingers, you need a hallway, and then you need something with small print like a pen. And with nothing else, you can effectively perform that exam.
Some of our listeners are asking follow-up questions on this. What about patients who have a previous history of concussion? How do they respond to these screening tests? Does that have any effect on their recovery trajectory?
Yeah, and when we look at the risk factors for persistent concussion symptoms, one of the bigger ones in terms of association is a prior concussion that took a long time to recover. In terms of the diagnostic utility of these tests, we've done a bunch of testing in patients without concussion to see are there differences by factors such as age, sex, underlying medical history, concussion history. And it turns out there really aren't. This performs as well in someone with 5 concussions as 0, in a teenager as a school-age child, in someone with something like migraine headaches who's not in the setting of an active migraine as someone without. So that's the other piece that we find really valuable about this testing is you really don't need a baseline. And in the emergency department, we'll never have access to a baseline. That allows it to be so useful and beneficial. In terms of its predictive power, similarly, if you have these deficits early on, regardless of your comorbid conditions or underlying medical issues, they are a really strong signal of having persisting symptoms. So that's the value in the vestibular testing, is that it can give you a diagnostic signal, it can give you a prognostic signal. And then I mentioned to folks to be thinking about like what day-to-day life might be like for patients as they're watching the videos, but it's also a functional test. And we use each of those individual elements hundreds of times a day. If you're a teenager in school, you're using them thousands of times a day. Horizontal saccades is reading, vertical saccades, looking up at a board and taking notes. So we can also begin to predict where a child might struggle in getting back into school. And coming back to the very beginning of what is our job, getting kids back into the school setting, we can be more effective that way by assessing for these deficits.
Thank you. Another follow-up question related to that. How much do medications affect the response to these measures? Presumably, pediatric patients may be getting meds pretty quickly. If that, does that mess up the use of these measures?
Doesn't in terms of use of the measures. The one caveat to that is migraine headache, and the Venn diagram of migraines and concussion has a decent amount of overlap. And while these deficits are helpful, they're not perfectly specific to concussion. So if you're in the throes of an active migraine and I do this testing, I'm probably going to find a lot of abnormal values, and that's why it is not a sufficient test. We need to be assessing for other pieces of injury. That being said, the other medications we traditionally use generally do not affect it. If you're going to have symptoms provoked, whether or not you've received an NSAID or an antiemetic, you're still going to have the symptoms provoked. The question of what pharmacologics could be using in concussion is another hour-long talk, because there's lots of interesting data. And some of our early data is that there is a quick bridge to medication overuse headaches for our patients with concussion. And compared to the ankle sprain, where we say use judiciously or as often as you want your over-the-counter analgesics, If for more than a few consecutive days a patient is using over-the-counter analgesics, it can really prompt medication overuse headaches. So that is why when I was showing the screenshots of the remote management that we're doing, we ask about daily medication use. And if we find a patient is using and relying on over-the-counter analgesics for more than a day or two, triggers an alert to us to reach out to give that guidance of, we really want you to try to avoid those. So this is one of the issues with concussion, is that those are symptomatic treatments. If we can get a pharmacologic that is much more targeted to the underlying physiology, it has a much greater chance of not only being successful, but also reducing negative side effects.
Can you say anything about the mechanism behind the beneficial effects of these branch chain amino acids?
Yeah, so there are a few features that we think are helpful. The 3 BCAAs are key elements of several neurotransmitters, including the excitatory neurotransmitters. And we talk about with concussion, there's this supply and demand mismatch in the brain, where energy demand is exceeding energy supply because of some compensatory vasoconstriction. So the BCAAs that are in the body get consumed up really quickly as the brain is healing, and that increased energy demand exists. Thought is by repleting them, we can kind of keep up with the energy demand. The other element that they are vital to creating, and the other protein they're vital to creating, is ATP. And again, thinking about that supply and demand mismatch, if we're consuming lots of ATP as the brain is recovering, we're depleting the BCAAs very quickly. If we can keep them in a steady state, then we avoid that. What's interesting in the animal models, if you give a single dose of the BCAAs, it doesn't really have prolonged effects. They have to be continuously exposed to it. So that is one of the interesting features, and also one of the challenges in conducting clinical trials with the BCAAs in humans, is this isn't you take a pill once and you're cured. We need patients to continue to consume the BCAAs over several days, if not a couple of weeks, to see the most benefit from them.
You hinted at a phase 3 trial that you plan to launch this summer. Can you tell us a little bit about it?
So this has been one of the more interesting features of getting this launched. So the BCAAs, to be able to consume them, and if you wanted to go to GNC right now, you could buy BCAA powder right off the shelf. The amount in that scoop of BCAA powder that you're taking is about 0.5 gram. If you remember from the graph, our values were up into 50 grams of BCAAs a day. So you'd have to take about 30 shakes a day if you're getting it off the shelf. And to turn it into a pill, be a pill that's about this size. So really the only way to concoct this and make this for a patient to drink is a concentrated powder that's dissolved. Protein tastes terrible. If anyone has an adolescent who's trying to bulk up muscle and taking protein shakes, they know that awful pungent smell that it can lead to in the kitchen. So the reason we've had some trouble in getting to the phase 3 is trying to figure out what is the palatability that will ultimately lead to adherence. So it's been about 1.5 years of various palatability testing. I think we finally hit the nail on the head, but we'll see what happens when we launch the trial in terms of how well tolerated the BCAAs are. From a side effect standpoint, there are very minimal side effects, even at the doses we're providing. It's really just tastes gross. And getting a teenager to drink something that tastes gross is a challenge in and of itself. So some really interesting lessons learned about just usability and working with adolescents in terms of, you got to listen to the adolescents, and we can design studies till we're blue in the face, but if there isn't a patient-centered approach to them, they're not going to work. And really tied to that launching of our phase 3 trial, we're also really excited about the fact that we just recently launched Minds Matter Patient Family Advisory Board that's made up of about 12 parents of pediatric patients with concussion and then teenagers themselves. So as we're thinking about these trials, we can in real time run by them, trial design, hear from them about study hiccups before we've launched the study, and really continue to engage them as we think ultimately about things like dissemination.
Thank you. We're not going to get through all of our questions today. They're rolling in faster almost than I can record them. And we're just about out of time. So let me thank you, Dr. Corwin, for a terrific presentation. Thanks to our audience for very good questions. As I mentioned earlier, we will be posting a recording of today's presentation on our website in the next few weeks. And I want to thank everybody for joining today's lecture. Thank you very much.
Thank you.